All right, well, let us get started. It's an early Monday morning, at least for me here in Phoenix. The rest of you have probably started your day for a few hours. This is Larry Boris. I'm Executive Director of the National Association for Workplace Healthcare, and we're very pleased to have you join us for this update on the HSA and on-site clinic provisions that were proposed in the Budget Reconciliation Bill. This is our first Monday roundtable. And for those who are not familiar with us or are new to our organization, we're the nation's only nonprofit group focusing on supporting employer and union sponsors utilizing direct contracting for medical and other services, particularly on-site, near-site, mobile, and virtual care. We also have services and support and assist our vendor and provider members in helping them understand this field and working best with employers. We offer a variety of educational programs twice a month. We have our first Monday roundtable, which you're participating for today. And then usually the second or third week of the month, we have our webinar. We've got some upcoming programs, as you can see. July 16th, we'll be talking about how to install direct contracting strategies. August 5th, we'll have a legal perspective on clinic accessibility in COBRA, and then a drill down later in August on understanding employers' population and culture, so that you can match your services and needs with that of the employer. Well, today, again, this is a roundtable, so this is slightly different than our usual monthly webinar. We'd like everyone who is on the call to just introduce themselves and their organization, title, and overall responsibilities. Then we're going to have a content expert. We're pleased to have Melissa Bartlett from ERIC, who I'll introduce shortly. She'll talk for about 30 minutes or so, and then open it up to questions, ideas, your own experience, your own information about these topics. And I'll be calling upon you individually at the end of the formal discussion. And we'll be recording this for people who can't attend and may want to listen in later on in the day. So with that, let me introduce Melissa Bartlett, Senior Vice President of Health Policy for the ERISA Industry Committee, or we affectionately call them ERIC. Melissa's Vice President, as I said, she leads the ERIC team that helps the National Association of Workplace Healthcare in its Fair Market Value Collaborative, our effort to change the fair market value requirement that a person with an HSA must pay a mandatory copay if they use an employer's on-site clinic for more than first aid and preventive services. She really supports all of ERIC's member companies in advancing policies relating to health benefit coverages and a variety of other issues. This clearly was a one small, tiny aspect of a whole budget reconciliation bill, but an important one is it's something that we've been working on for almost 2.5 years now. So with that, again, let's welcome Melissa Bartlett. Thank you very much for joining us, and I'll step away for a moment. Melissa, back to you.
Thank you. And Larry, did you want to go around and have folks introduce themselves first? Or do you want me just to jump in?
Of course, I don't follow my own instructions, so here we go. That's very good. All right, so when I call your name, please just identify yourself, your title, and your organization. So Bhavin Patel, would you introduce yourself, please?
Hi guys, I'm with Walk On Clinic. I'm one of the co-founders, administrator, you name it, right now wearing all the hats. We're a mobile healthcare company that goes on site to employer groups. We do annual wellness biometrics, and we fractionalize the DPC model for small to mid-sized companies.
Great, thanks very much. We've got somebody who's just got a phone number, a 615 number. If you'd introduce yourself, identify yourself, please. If not, Shelly Kiwala. Shelly, introduce yourself, please.
Yes, hello, good morning. So I'm Shel Kilawa. I work for HII. We are a defense contractor. I oversee all of our health and well-being benefits. I'm a corporate benefits manager, and that includes our 3 on-site clinics.
Great. And HII is Huntington Ingalls Industries. Deanna Hahn. Deanna, you want to introduce yourself, please?
Yeah, hi, I'm Deanna Hahn. I work for SSM Health, and particularly our SSM Health at Work division, so covering occupational health and on-site near-site clinics.
Great, thank you. John Z. Holt. John Z., introduce yourself if you would.
Hi, I'm Johnsy Holt. I am with Metro Nashville Public Schools, and I'm the Director of Employee Wellness and work with our 5 on-site near-site clinics.
Great, thank you. Julie Gilliam. Julie, introduce yourself, please.
Julie Gillum. I work for Optimal Health Initiatives, and it's a trust of schools and public employers, libraries, and ESCs,
Great,
and they have clinics.
great.
And
Thank you very much. Oh, go ahead.
I'm good, thanks.
All right. Justin Slatke. Justin, introduce yourself.
Hey, good morning, everybody. Justin Slackey with Estia Health. We are an advanced direct primary care provider in Wisconsin, and we provide various near-site and on-site clinic services to small, medium, and large employers in our area.
Thank you. Kendall Rosemeyer. Kendall, introduce yourself if you would.
Yeah, yep. Kendall Rosemeyer with Chief Health. We run direct primary care clinics in Minnesota and Wisconsin. So happy to be on this call today. Thanks.
Thank you. Lillian Shields. Lillian, introduce yourself if you would.
Good morning. Thank you, Larry. My name is Lillian Shields. I'm the strategy manager of community partnerships for Intermed, which is a physician practice in Southern Maine. We have 2 on-site clinics at 2 large employers in Southern Maine. We offer both OC and non-OC services.
Thank you. Melissa Hogan. Melissa, introduce yourself if you would.
Yep. Good morning. I'm a senior vice president with Aon and a specialty practice, and I lead our employer-sponsored advanced primary care practice for the firm.
Thank you, Melissa. Michelle Storbakken. Michelle, you introduce yourself.
Yeah, Michelle Storbakken, Senior Vice President of Innovation and Product Development for Quad Med. And we have on-site, near-site health centers, primary care with a variety of other services. I work closely with Shell. So
Great. Thank you. Nicole Miller. Nicole, introduce yourself. Nicole, take yourself off mute. Okay, Nicole's with MedCore. And finally, Thomas Hall. Thomas, if you'd introduce yourself.
Yes, Thomas Joe, National Account Director for Employers with Pfizer.
Great, thanks very much. I think I've covered everyone. Melissa, I'll turn it over to you to give us that update and briefing. Thank you.
Great, thank you, Larry. And it's nice to be here with everyone today. It has been quite a wild journey in Congress so far this summer, with all activities laser focused around passing the One Big Beautiful Bill Act. That's the Republican tax package that included a number of other provisions. It went through a process that's referred to as the reconciliation process. And the reason that's important is that the reconciliation process itself is a truncated process by which the party in power here, the Republicans, would pass a number of reforms on the Senate floor without having to face a filibuster. So they only needed a simple majority of votes to pass the package, as long as, most of the things that were included in the package survived what a lot of folks call the Byrd rule. Essentially, at the core of it, it means anything that was going to be done through this sort of fast track reconciliation procedure really has to hit certain fundamental key directives for using the process, namely around it needs to be truly a spending or savings bill, right? You can't have policies included that you throw into this because it's a moving vehicle that do not have as sort of their base core fundamental purpose some kind of spending or savings purpose or impact. So if something isn't going to score as a savings, it doesn't score as a spending, probably can't go into a reconciliation package. Otherwise, it would trigger the filibuster, and then you'd have 60 votes to pass it. So with that background, again, it's not unusual for any political party that has control of the House and and the White House to want to use this reconciliation process as a way by which to push forward some of the more controversial policies that the party wants to advance. Here, the trigger was there's a number of tax provisions that expire that were put through a reconciliation process during Trump 1.0, the last time the president was president. And so they wanted to make a number of those provisions permanent and or extend them. Doing so, however, was very, very, very costly. And so it became, if you've been following in the news, quite a challenge to try to get to yes when the House only has a Republican majority of, 2 votes, 3 votes. And the Senate has a little bit more breathing room, but surely not 60 votes. And so getting to yes on what things to cut to pay for these tax extensions has proven quite challenging. You've probably read about the cuts to Medicaid. You've probably read about a number of members on both sides of the aisle have long been, fairly sore about the SALT, right? The change in the SALT calculations for property deductions. So, there's just sort of key issues that are very have been driving this one big beautiful bill, and whether or not it would successfully be enacted at a very high level. And so I say that to explain that, our work site bill, which we've worked on for many years now with you guys, was included in the one big beautiful bill act as it passed the House side, right? So the House included a number of provisions that survived that Byrd rule determination. So there's still some kind of financial spending savings impact. And two, didn't add so much more spending to the bill that they couldn't offset the bill. And then that would be a problem in and of itself. So the number of sort of high deductible health plan and HSA bills that had previously in previous Congresses cleared the House Ways and Means Committee were included in the underlying bill that passed, the version that passed the House side, including the worksite bill. However, when it went over to the Senate side for passage, the Senate wanted to, due to a variety of political considerations, like I said, a much higher level than just what our little work site bill was. But in order to get to 51, because there were a few holdouts on the Republican side that said they just wouldn't vote for this package because it didn't fully address, deficit spending, et cetera, or any whole host of reasons. In order to get and guarantee that they had the 51, they stripped out any of the sweeteners that had passed as part of the OBBBA from the House. And it was sort of like, okay, we're going to do the bare minimums, the fundamentals, the tax reform extenders, and a handful of other things to pay for that, like the Medicaid provider tax provisions. But we're not going to add any more to the table because then we're going to have to find more savings to add to the table, unless this is really something that's baked, ready to go, has to happen. People will die on their sword if it doesn't happen right now. And so, unfortunately, what happened is some provisions that passed the House version of the bill ended up being added back in. Then some of those were related to high deductible health plan and HSA policies, such as the permanent provision of first dollar coverage for telehealth services. That's now permanent, which was very important for those that are interested in that policy. It's a policy that for many, many years and many, many, many groups have been organized and leading a fairly intense, extremely active campaign to try to get that done. There also was another HSA bill that, again, just like our worksite clinic bill that passed both in the Ways and Means Committee the last couple Congresses and then as part of the House version of this reconciliation bill. It was a bill that addresses, direct primary care arrangements for HSAs. That was also included in what has now become law. However, the remaining list of high deductible HSA bills that had been included and had been voted on and passed by the House in, I'll just say HR1, that's the One Big Beautiful Bill Act, they remain cut. And so our worksite bill was not included. Obviously that's fairly disappointing to say the least. However, Tim Scott, Senator Tim Scott remains our champion. He sits on all the right committees. He sits on Senate Finance Committee. He did introduce the bill, and he ahead of this whole Senate budget reconciliation process. We've been working very, very closely with his staffer. I think at the end of the day, if you can understand the context by which the Senate was trying to get to yes and figure out what are the political sweeteners that could get them there. This wasn't one of them that would have gotten them any more votes on the overall package. So it wasn't something that they could really insist had to be included. Plus, it does have a score attached. Now, so does the permanency of telehealth, first dollar coverage, as well as DPC. But the difference is, I think, with those versus the rest of the provisions on HSAs that had been included in HR1, they just weren't as ready for prime time, I think, as those two HSA provisions. Again, we've been told if money was not the limit, but for that, that's why that was dropped out in the Senate and just, wasn't able to rise to a top priority to put back in. Again, this along with other HSA items in the Senate, were out because of the money associated with this policy. House side champions remain in place. We have Congressman Mike Kelly, who's a Republican from Pennsylvania, and Terry Sewell, who's a Democrat. But again, because of what I mentioned at the start, that this whole process was so partisan, there was no way that she would get on board with introducing the bill with Congressman Kelly. But she is supportive of the bill and has been a lead in the past. So in many ways, as we look forward, perhaps the partisanship of the reconciliation process will be behind us, and we can work across the aisle and across the hill in the two chambers to identify ways to push this through this year. Like we said, we're still waiting for a CBO score on the 117th version of the Ways and Means and Senate Finance Committee, for the Ways and Means and Senate Finance Committee to consider the 117th version. The 118th version did get cleared, but it got cleared with a score. We prefer the 117th version. It's broader. But again, we're not quite there yet. The next step again should be that once all this dust sort of settles, what is the next moving vehicle and the bill's chances for inclusion? We know that Congress has to enact, I think it's 12 appropriations measures to keep the government fully funded after September 30th of this year. So it's highly unlikely that between now and September 30th, the House will have passed and the Senate will have taken up and passed all of these appropriations bills. That means that there'll heavily likely be a continuing resolution to keep the government funded past September 30th to some date, unknown at this point. So that quote CR could carry policies There could also be a end of the year healthcare bill. We know that a number of bipartisan, bicameral healthcare policies have been agreed upon for the end of the year appropriations package last December, but then ultimately got cut because of Elon Musk twittering that the bill was too big and it needed to be cut. But those policies themselves, again, the work has been done. They've been agreed upon by House and Senate leadership, Republican and Democratic leadership, and scored and drafted and ready to go. They got pooled literally the night they were supposed to go with the larger appropriations package last December. So that's sort of on the shelf. Knowing that's on the shelf, and there are a number of really important policies that are expiring or need further funding or just highly supported in a bipartisan way in healthcare that are sitting in that package on the shelf. I have to think that there could be an opportunity for a year-end healthcare package as well, either as part of a funding bill or a separate. And then there's, talk of another budget reconciliation coming around. So we'll see. I think our next action items here at ERIC are we're going to be checking in with the Ways and Means folks and with Congressman Kelly and Congresswoman Sewell's folks and find out, as our champions and as the committee of jurisdiction that passed HR1 with this included, how can we help support them, support us getting these policies done this year? And if there's any timing, pieces we can pick up from them on when they project that this could be back up for a vote. We would again have to think about maybe ramping up our engagement and again, we weren't quite the level of engagement that the telehealth folks had, the direct primary care arrangements folks had, and that those folks have been bringing patients, many, how many patients, how much data, they've just armed themselves to hammer the hill with the real patient impact of these policies. And so I think to the extent that we can really try to get our hands around robust data about what worksite clinics offer for the workforce, in addition to employers, but more so for the patients and their families, and especially at a time where there's a workforce shortage of primary care physicians, I think that would be helpful. Larry, I can stop there and we can have a discussion if that's helpful.
No, that's great. Thank you very much, Melissa. So before we start out, let me reinforce what Melissa's just said. If you're really interested about getting this fair market value requirement modified so you can offer services at your centers without people having a mandatory copay if they have an HSA, so please collect and share with us information you've got that demonstrates the value of the centers, cost savings for the individual, access, improved quality, whatever you've defined as a value that, again, can be used to convince our policymakers to adopt this kind of legislation, and just share that information with me. So with that, I'm just going to go around the table based on how you're listed on my computer, and feel free to ask a question or contribute some information. So Tony Musi, Tony, any comments, questions you got? Take yourself off mute. If not, Beth McIver, I'm sorry, Beth. Beth, comments or questions? Okay. Bhavin, comments or questions?
No, I'm good right now.
Okay. Shelly, any comments or questions?
Nope. I mean, I just hope that we can continue to push this forward and find a resolution that works, for our employees and the American people. But But we actually honestly only have a very small population on HSAs, but it could be nice to be able to offer those again.
Gotcha. Thank you. Kristen Wire, Kristen, comments or questions?
No, it would have been very helpful. It definitely creates issues for HSA plan participants, and because of the first dollar coverage portion, you have to navigate carefully, and it doesn't allow us to get full use of our on-site clinics. So, yeah, it's unfortunate. Thank you for all of your efforts, though, and happy to help contribute if we can, help gather data, et cetera, for the future.
Great. Yeah, again, just send that any information to me. Deanna Hahn, Deanna, comments or questions?
No, just appreciate all your efforts and echo what Kristen said. It's disappointing, but hopefully we can keep working on it.
Thank you. John Mark Franz, John, any comments or questions?
No, just we were hoping that we would be able to get it through, but we've got employers that are asking these questions certainly, and that's unfortunate, but we can keep trying, right?
Yeah, absolutely. Thank you very much. John Z, any comments or questions? John Z. Holt?
Nope, I don't have anything right now, but thank you all very much for the information.
Thank you. Julie Gilliam, Julie, comments or questions?
Did you repeat the two things that did pass for the HSA, the telehealth first dollar? Or Melissa, I can't remember the two things.
Yeah, oh yeah, it was the first dollar, coverage for telehealth, and then it's also direct primary care arrangements.
So how does the direct primary care then, what's that been modified to? You're on mute.
Yeah, let me look that one up so I can tell you exactly what it does if you can let me look that up. I don't want to.
Sure.
This is Kristen. I think so for individuals who have an HSA that opt to pay like a direct primary care provider for more, I sometimes refer to it as executive almost level care, where they have access to a provider for 24 hours a day, 365, and they pay a monthly fee. I believe it now makes it such that they are not ineligible for an HSA. But definitely double check that, Melissa. I don't really see, in my opinion, how that's any different than an employer clinic arrangement. So I was like, why did that get through? But the employer clinic piece didn't.
Yeah, frustrating. Justin Slacky, Justin, comments or questions?
Yeah, I don't have a whole lot. I guess I would just echo what others have been saying, especially Kristen, about how it's just a little disappointing with this remaining in there. But especially for those of us, and I'm sure I'm not alone, but we work a lot with blue collar manufacturer employers, and for their population, especially those that are on a high deductible health plan, I mean, they're not making bank on a monthly basis. So for like a family of four that's on a high deductible health plan, I mean, if each one of them gets a visit in a month, you're looking at somewhere around $100 that they could possibly shelling out in copays, which is a significant portion of their monthly income when they have to make a decision between healthcare and groceries or other essentials that they need. So I think that's an important thing to kind of echo to our policymakers, is that this is affecting a lot of hardworking folks who aren't making a lot of money, and it can be a real barrier to access to healthcare, even if they are being offered access to a near site or an on-site clinic by their employer.
Great. Thank you for those comments. Kendall Rosemeyer, Kendall, comments or questions?
Nothing additional, just appreciate the information and echo everything everybody's already said. So
thank you. Lillian Shields, Lillian, comments or questions?
Thanks, Larry. Thanks, Melissa. I appreciate it. Melissa, are there any substantive changes to the part about employer health centers that was put in this session opposed to the past few sessions, or is it sort of the same gist year to year, or I should say Congress to Congress?
Yeah, so the version that was included in HR 1 before being stripped was the version that passed the Ways and Means Committee last Congress. And that version had to be fairly narrow in terms of the services that would be impacted by this and offered through the worksite clinics compared to a previous version from the previous Congress that we had written and supported. And the reason it had to be narrowed was for cost considerations and to try to keep it as a bipartisan bill for markup. So we had fought last Congress tooth and nail to get a previous version reintroduced and marked up that was a bit broader. And at the end of the day, they could only do what they did, which incidentally actually tracks a previous version to the previous version. So that tells you how long lawmakers have been like looking at this as a policy and trying to do something here. But in any case, again, it kind of depending on the Congress, it's sort of flipped back and forth a few times. This is the version from last Congress that was a bit narrowed compared to where we would like to be. And we've been working with Senator Scott to introduce the version that is a bit more broader.
And
I
you
see.
said broad means scope of services.
Yes, I know, Larry.
Okay, thank you.
Yeah.
Yeah,
Awesome,
I mean,
appreciate it.
I was gonna say our original proposal was to include as much of the current services that worksite centers are offering in front of the deductible as opposed to behind. So primary care services, mental health services, pharmacy services, disease management services, etc. We are trying to get so there wouldn't be a first a payment a deductible required ahead of that. So the mandatory copay. So I think there was some allowance that let people use an on-site clinic. I don't know, Melissa, is there an opportunity to change the definition so we can include any employer type like near site and shared and virtual?
I mean, perhaps I just think the issue we have at this point is that it's just even trying to get it to go back to a version that has already passed the committee that was broader has been difficult because of the cost, right?
Sure.
So, I mean, that's how we ended up kind of where we're at now because there was a whole panoply of HSA provisions that were included in HR1 before the Senate cut them all out and then decided to like pick and choose and add them back in. And if you look at the score for HR1, ours was not the most expensive, but it wasn't zero either. And it sort of fell in that sort of pool of other HSA policies that were right around the same price point. So they sort of picked out the two that were most baked and left the rest of them on the table. So I would say that if we tried to expand it, it'd probably increase the score and actually might be more difficult to get over the finish line in the immediate future.
So do you think our strategy is going to have to be to ratchet down to the bare minimum of what we think we want just to put a camel's nose under the tent, so to speak, to get started? Or is this not something that, do we need to change totally our approach on this?
I mean, it might be a bit of both. I'd have to do a little bit more digging around and the follow up with the committee staff and with the Scott staff, the Kelly staff about this. But it's two things. I think one, the score definitely was what was relayed to us. I mean, it was easy sailing in the House and then came unraveled in the Senate, and that's because the Senate had other things that were offsets of begin that the parliamentarian ruled out of order and too politically impossible to do. So then they were sort of juggling the math about okay, how much money do we have to spend here? And coming up short if they did all the various HSA provisions. And so they picked kind of the two that made sense to them at the time. Now, I think adding to the score is never a great thing, and I think narrowing it down might increase your chances of getting it done because that's not going to change. They're always going to want to offset spending. And so if you see a $2 billion price tag on something, that's a lot of money for them to try to figure out how to come up with even in a broader appropriations package or a broader healthcare package. It's not a terrible thing, but I don't know that what does it get you if you narrow it down to not being that meaningful. You can always expand it over time or write it vague enough that allows the IRS to expand it over time, I guess. Maybe find a way to like write something in a way that the Joint Tax Committee won't read in the score, but the IRS will read in lots of flexibility. That would be ideal, right? But I mean, I think the other thing is that just really to the point, Larry, you were saying, do we have to change our tactics? I do think we need to step up our tactics a bit and change them a bit. And we've talked in the past about shifting this from talking about fixing a high deductible health plan HSA provision, which makes Democrats sort of recoil, right? They don't like the idea of helping HSAs at all, to making this an issue of patient access to care and what meeting the patient where their care needs are. And that might be at work. And guess what? It's way more convenient and better for the patient to get those services there than have to find a primary care doctor if they can and get into one if they can, and then have to take off work and drive 2 hours to go there and everything else. So the data points are going to be very, very important to have around all of that. And I think, I don't know if it was Lillian or whoever it was talking about the blue collar workforce angle. You know, the unions are the ones that kind of held us back when we were very close to getting a lead Senate Democrat with Rosen. No, it was Cortez Masto. Trying to remember, Cortez Masto last Congress, and at the end of the day, it was the culinary union that basically backdoored into them. We don't support anything that supports high deductible plan HSA, so don't do it. Um, so I think if we have insight and reach and relationships with certain unions, then getting them to understand and really promote the value of this for their membership, I think would also be helpful.
Great. Thanks very much. Okay, Michelle Starbroken. Michelle, comments or questions?
Yeah, no, I echo what everybody else said, but I guess my question would be, Melissa, I mean, you just alluded to it a little bit on, what data has been submitted already and what different data you think would have an impact in getting this passed that you don't have. Just maybe a little bit more specificity around what would be helpful that you don't already have.
I think I might turn it back to Larry because I know he was sort of the gatekeeper of collecting the data. But I know in terms of just being able to get to, the members of Congress, they care about what's happening in their backyard, clearly. So it's showing them X number of patients in your district or your state are using a worksite health clinic to meet these kinds of primary care needs. They're doing it this often. Their family members are using it. That kind of stuff I think is helpful. I think showing how many primary care workers are working through the worksite clinics, right? Are choosing to go and be employed in that staffing kind of way is helpful too. So that, when you're talking about a primary care workforce shortage, like Congress is very attuned to, and they get it and they're worried about it. You can say, look, these are the PAs and the NPs and the doctors that, may have had a small practice or a practice outside of town or whatever, but now they're coming and they're staffing these things. So we should be driving patients to see where they are, right? Or to go find them. This is where they are, right? This is the gap in access. So
Right.
yeah.
Okay.
Yeah, so I
And
mean,
then I think, yeah, go
our
ahead,
focus had been on those that were on certain committees, like the Ways and Means Committee or others. And so we were really focused on getting data for those particular legislators. And we continue to have that list. So, but I would say, if there's any way you could identify the number of lives covered in in the states that you have operations in, uh, issues of access, as Melissa said, the providers that are available, we just completed our national survey. We'll come out with it soon that talks about the percent of people that are not offered or do not have doctors that use the center as their sole medical home. So that'll be helpful as well. But whatever information you have that shows how worksite centers are improving access to care and improving quality is really, really helpful.
Thank you, Larry. That's really helpful.
Thank you. Lastly, Thomas Joe. Thomas, comments or questions?
No, good information. No questions at this time.
All right. Anybody else have a comment or question before we let Melissa go? If not, again, thank you, Melissa, for your time and the last minute efforts and all of your efforts. And again, for those on the call, please, if you're interested in this topic, if this is important to you for your workforce or for your client base, please consider supporting the Fair Market Value Collaborative. Grants are needed to maintain this activity and enable ERIC to be as aggressive as they can. And please, if nothing else, submit your data to us about what states you're in and the lives you're covered and the value of the center. So with that, again, thank you everyone for taking time out of your day. Thank you, Melissa, and stay cool this summer and try to stay dry. Thanks, everyone. Hope to see you at the next program. Bye-bye.